Hello, everyone. We are live in our NCLEX RN review today. And so kindly let us know where you're watching from. And so for those newcomers, we're currently on the 15th day of our 90-day free NCLEX review series, and we are covering into all nursing subjects, providing explanations for 2000 NCLEX-style questions. And don't forget to spread the word to your friends preparing for the NCLEX, and kindly like, subscribe, and also enable notifications for the updates. And I really need you to check the description box below for more details. And again, we value your comments and your feedback. So feel free to share your thoughts or questions in the comment sections for clarification on any discussed topics. Now we're also offering the NCLEX course at Stancoast, nclexcoaching.com, and we want you to dig into each topic with straightforward lectures and also challenge yourself with a huge bank of over 3,000 NCLEX style questions and an additional 5,000 nursing brainstorming questions. And we do have an audiobook and the bullet book that are perfect for your quick review sessions. And we have 100 hours of dedicated NCLEX preparations, and to make sure that you are engaging in our 10-hour animated video course and also learn into our material with our extensive library of on-demand videos and test your knowledge with mock exams and also comprehensive test series. And this is something that you can enjoy for a full 6 months with your access, and this you can do 24/7. Now, included in our package is the 200 NGN questions to further enhance your preparation. And this is something that you can do, again, 24/7. So we really encourage you to consider this course as your ultimate comprehensive NCLEX preparation. And so for today, I'll be talking about the COPD, which is a commonly asked disorder in the NCLEX. Now let's get started. Now, this is a very crucial topic, especially in the upcoming NCLEX RN exam and for your future nursing practice. Now, the general characteristics of the chronic obstructive pulmonary disease is primarily composed of the two conditions. So it could be the chronic bronchitis and emphysema, and these two are actually going to overlap. And so let's break them down. Now, what is this condition? Well, basically, this is going to be an irreversible condition. And with a chronic bronchitis alone, this is something that is going to be diagnosed clinically, which simply means that if a patient has chronic cough and also producing sputum for at least 3 months each year or for 2 consecutive years, then they are diagnosed with chronic bronchitis. Now, for the emphysema, this is something that is diagnosed pathologically, meaning that it is identified by examining the lung tissue. And this is going to involve permanent enlargement of the air spaces, which is its hallmark, really, which is the enlargement of the air spaces, the alveoli, beyond the terminal bronchioles. And this is because of the destruction of the alveolar walls. Now, even though we distinguish between chronic bronchitis and emphysema, they often coexist, and pure forms of either conditions are somewhat rare. Now, with the COPD, it's a major health issue, and this is actually ranking as the third leading cause of death in the US. Now, let's go into the different factors that can increase the risk of developing COPD. Now, first and foremost here, please be reminded that tobacco smoking is the leading cause, and this accounts for nearly 90% of the COPD cases. Again, that is the tobacco smoke. Now, genetics also can play its role, specifically when there is a deficiency in the alpha 1 antitrypsin. And this genetic risk is even higher if the person is going to smoke. Now, The environmental factors can also affect, or this can contribute to COPD, and namely the pollutants like secondhand smoke can also contribute to this one. Now, for those people that have pre-existing asthma, this is also going to be a risk because there is that condition we call as the asthma COPD overlap syndrome. This is going to progress into a chronic obstructive pulmonary disease. Okay, so I really want you to refamiliarize yourselves about the risk factors and the distinct differences between the two. And like I've said, these emphysema and chronic bronchitis can overlap. All right. Now let's move into the pathogenesis of the COPD. So we're going to discuss about how it develops and also looking into the differences between the chronic bronchitis and emphysema. So as we know, this is a very common fact that the chronic bronchitis are typically known as the blue bloaters, right? And so with this condition, there is excess mucus production, and this will now lead into the narrowing of the airways, which can actually cause the obstruction. Now, again, focus onto the chronic bronchitis. We're talking about the mucus production that can narrow the airways, which actually gonna block the passageway. Now, this is something that can be accompanied by the inflammation or the scarring, or it could be the enlargement of the mucus glands. And this is also going to be associated with those hyperplasia of the smooth muscle. And as an end result, this is going to cause the patient to have a productive cough. So looking into the photo right now, so comparing the healthy airway, have that clear passageway, comparing it with the airway in a patient with the chronic bronchitis. There is significant narrowing of the passageway and mucus production as well. So this is going to be the key hallmark of this patient. All right, I want you to recall, if it's bronchitis, think about the mucus secretions in the airway. All right, now moving into the emphysema, they are the pink puffers. And this is a condition that actually results from the imbalance between the protease, like the elastase, and also the alpha-1 antitrypsin activity. So I really want you to draw into this. The emphysema is the imbalance between these two substances, the elastase and the alpha-1 antitrypsin. So basically, the elastase is the enzyme that breaks down this substance where it can impair its functioning. It can impair the action of the alveoli, especially during the ventilation process, where it can cause impairment in its what you call this inflation and deflation. Now, normally the alpha 1 antitrypsin is going to inhibit the elastase, which is that enzyme that will destroy the functioning of the alveoli. And the alpha 1 antitrypsin basically is released from the elastase, is actually released from the neutrophils, or the antitrypsin rather, is released from the neutrophils and the macrophages to protect the lung tissue. However, though, when the person is smoking, this is going to increase the number of these activated cells and will inhibit the alpha 1 antitrypsin. And this will now cause oxidative stress through the radicals and leading into the destruction of the alveolar walls. Now, we're going to have to talk about the different types of emphysema here, simply. We'll just simplify this. And so there are two types here. And the first one is what we call as the centrilobular emphysema. And this is the most common type, especially among the smokers. Again, the central lobular emphysema is the most common, and this is occurring mostly among the smokers. And what is affected here are the respiratory bronchioles, especially the proximal acini, while they are going to spare the distal acini and typically are seen in the upper lung zones. So I'm showing you right now where this central lobular type of emphysema affect. So they're actually going to affect directly into the respiratory bronchiole. All right. So look into that hyperinflation of the bronchiole itself. That's why it's called centrilobular. Now, the second type is the panlobular, and this is going to be associated with the alpha 1 antitrypsin deficiency. And it actually looks like this, affecting directly into the alveoli. So now it's hyperinflated, right? And looking into the bronchiole, they are not affected at this point. And so with the panlobular emphysema, this is associated again with the alpha 1 antitrypsin deficiency, and this can affect both the proximal and also the distal acini, and this is usually seen in the lower lung zones. Okay, so these are again the two types of emphysema. Now let's move on into the different manifestations in a patient with the COPD. All right. So again, like I've said earlier, both bronchitis, acute bronchitis, and the emphysema can overlap in this particular patient. Now, the patient here will basically experience a combination of the symptoms like cough, which is the hallmark. There's also sputum production that is excessive, and they're going to end up with shortness of breathing, difficulty of breathing. And one of the earliest and often unnoticed symptom is the exertional dyspnea. So this is something that can be easily missed, especially for those patients that are less active. Those are sedentary, just staying at home, nothing, they're not really doing a whole lot of activity. So this is something that can be easily missed. So pay attention about the exertional dyspnea. This is probably something that you might not see right away. And so, yeah, you really have to assess your patient carefully. Now, there's also going to be a prolongation of the expiratory time. When they're going to exhale, they're going to have this classic lengthened exhalation, and they're going to have that pursed lip breathing. All right, so this is classic to the COPD patients. And along with that, they're going to have that end expiratory wheezes when you're auscultating them. So that musical sound that you're listening with, of course, when you're listening the patient's chest with a stethoscope, that end expiratory wheeze is very audible. And there's now a decreasing breath sounds, probably some inspiratory crackles, and you probably would hear or actually observe the patient that their respiratory rate is getting higher. The heart rate as well will go up. And in some cases, when the hypoxemia becomes much worse, they will become cyanotic as well. And with their respiratory muscles, they're going to use those accessory respiratory muscles. And when you're going to have to do the percussion into their chest, there will be hyperresonance. Again, hyperresonance is something that you can hear more often in a patient with emphysema. Again, hyperresonance simply means that there is now hyperinflation of those alveoli, right? There's way too much air retained inside the air sacs. So that is a classic sign of the emphysema. And when you're auscultating for the heart sounds, because of the increasing rib cage in the emphysema patient, because they are going to try to accommodate that chronic enlargement of the alveoli, so the chest will end up being larger this time. So when you're auscultating for the apical sounds, heart sounds, then you're gonna have this distant, somewhat kind of muffled but more often distant heart sounds. Now, additionally to that, you are going to look for signs of the cor pulmonale, and this is a condition that is basically caused by the pulmonary hypertension. And so this pulmonary hypertension is something that you will see in this patient with a COPD. There is such high pressure in the pulmonary arteries, in the pulmonary trunk. And so when this happens, this can cause the right-sided heart failure. Let me correct that one. Right-sided heart failure. All right, let me go back. All right, where are we at? Not quite sure if we are on the same page. All right. Okay, here we go. So again, we are seeing the cor pulmonale. Hang on a sec. I think our screen is not synchronizing. Okay, going back to that complication, which is the cor pulmonale. This is again a complication to the right-sided heart failure. And so I mean, the cor pulmonale is in itself a right-sided heart failure because of the pulmonary hypertension. So in this case, what you're going to have to see is that you're going to have to look for those signs of the right-sided heart failure, wherein the patient will end up with syncope. There are going to be some shortness of breathing. There will be fatigue. There will be also weakness. And you will see that the patient will end up with some edema, and this is going to be generalized type of edema, all right? As we know that there is now congestion of the fluids into the venous system. So again, pay attention into the presence of the edema. And this could be generalized anasarca, or it could be bipedal type of edema or ankle edema. And some of these patients might suffer the nun or pitting type of edema. Now, here, please pay attention here because the patient with the cor pulmonale basically will end up with some chest pain. And this is because of the increasing workload of the right side of the heart. And they're going to end up with the palpitations. They're going to have that cyanosis. And this is because of the decreasing oxygenation. And again, because this is now going to cause the backflow of the circulation into the venous system. So the patient will have that JVD again, the jugular venous distension. Okay. Now, part of that would be the ascites. Why? Because the backflow in itself in the venous circulation can also cause some problem into the portal circulation. Let's say the blood vessels actually supplying the liver. So with various backflow of the blood, with the increasing pressure into that area, this can now cause issues in the liver itself, and this will lead into ascites. So there will be now enlargement of the belly as to the presence of the fluid inside the peritoneal space. There's also going to be enlargement of the liver. And because of the decreasing oxygenation to the brain, sometimes the patient will complain of lightheadedness. And if the hypoxemia becomes much more severe, they're going to end up with some syncopal episodes. All right. So this would really cause them to fall at some point. Now, I hope that we are, yeah, I think our screens now are somewhat synchronized this time. And so at this point, we are going to talk about the diagnostic tests. So I hope that you have learned this in the past, but I just want to make sure that you're going to be refreshed about these section of the COPD in order that you can get refamiliarized in order how, if you can, so that you can properly educate your patient as you are going to send them to these different diagnostic tests. So one of those testing is the pulmonary function test, or known as the PFTs. All right. And this is going to be done as a spirometry. And this is going to be the gold standard for diagnosing the COPD. Again, this is the gold standard of diagnosing the COPD. So you'll see here the person being assisted by the respiratory therapist. So they're going to be using that kind of device in order to measure the different capacities their lungs can do. So they're going to use that mouthpiece, and they're going to be instructed into the different steps here. Now, talking about the PFTs, or the pulmonary function test, the key indicators basically will tell us that there is now going to be a decrease in the FEV. Please pay attention. This is a value that is commonly asked in the NCLEX, FEV, which stands for the forced expiratory volume in 1 second. Okay, again, the FEV1 is actually going to be decreased in this patient with a COPD. And again, this is the forced expiratory volume in 1 second. And there's also going to be a decrease in the ratio of FEV1 and the FVC, which is basically the forced vital capacity ratio. And we're going to talk about more on the staging here. So the FEV will be categorized into different levels of severity. So when the patient has, let's say 80% of the predicted value, then they are considered to have a mild FEV1. All right. Now, if they're going to have at least an FEV of 50 to 80%, then they're going to be categorized as having a moderate, okay, with a COPD that they're having. And the severe will be considered if their FEV1 reading is about 30 to 50%. And a severe form of COPD is going to be diagnosed when their FEV1 is less than 30%. Okay, so I really want you to focus into the FEV1. This is the total amount of air that a patient can forcefully exhale in 1 second. Again, FEV1 basically is the total amount of air that a patient can forcefully exhale in 1 second. And so if there is a greater amount of exhaled air, let's say 80%, that is already considered a mild form of COPD. So meaning they're not fully exhaling. It's not like 100%. So there is some residual air retained in the alveoli. Now, comparing it to the severe, very severe form of COPD, then they're not going to be able to really exhale the air outside, okay? Or they're not going to be able to empty the alveoli. So they're only capable of emptying at least less than 30%. So meaning they're actually retaining a whole lot of the air inside the alveoli. That's the easiest and the simplest explanation about the FEV1. The greater the amount that is retained, or they're not able to expire or exhale within 1 second, then the severe form of COPD is going to be diagnosed. Okay? Now, talking about the total lung capacity, what is this? The total lung capacity actually has a normal volume of about 5 to 6 liters, and we are talking about the amount of air that the lungs can accommodate. That is the capacity of the lungs that they can accommodate at some point. So talking about the total lung capacity, this is going to be increased in the COPD. Why? Well, because the alveoli are hyperinflated, right? Remember, and chronically, as time goes, this is going to be hyperinflated. So the longer the COPD is going to occur, then this will allow much more retained air into the air sacs or the alveoli. So that simply means they're going to be hyperinflated. So think about a balloon that is super inflated. You're blowing way too much air into the balloon. And so this is your total lung capacity. This is again increased in the COPD. Much greater than 6 liters, right? Maybe about 7 or 8 liters. That is what it's trying to um, signify. Now we're going to talk about the residual volume. So what is this residual volume? This is the amount of air that is remaining in the lungs after a maximal exhalation. Again, the residual volume is the amount of air that remains inside the lung after a maximal exhalation. So the value normally in a healthy adult, the normal residual volume is about 1.2 to 1.5 liters. However, in the COPD, it will be much greater than 1.5 liters. Imagine that. Much more of retained air inside the lungs. Now, talking about the next study here, which is the functional residual capacity, or the FRC. This is basically the volume of the air that will remain in the lungs at the end of a normal passive exhalation. So you're just going to instruct the patient to just breathe normally. They don't have to do any deep breathing at all, just normal. So again, this is the amount of air that will stay in the alveoli at the end of a normal passive exhalation. So again, the normal value in a healthy adult is 2.5 to 3.5 liters. However, if you have a patient with a COPD, the value will be greater than that. Simply means that there is still, again, there is going to be a significant amount of air that will be left inside the alveoli. So it kind of sounds like repetitive, right? But again, there is such the difference here because of the way that we are going to ask our patient if they're just going to exhale normally or if we're going to ask them to exhale forcefully. All right. So these are just the minor variations between these tests. So I hope that you're able to capture these. Now, overall, when we are actually sending the patient to have the PFTs or the pulmonary function test, this is definitely only to evaluate the lung function, the mechanics, how the lungs can actually do the proper exchange of the gases. And this is also going to evaluate how the lungs are able to maintain the acid-base balance. And again, the PFTs will involve the use of the spirometry. So this is the machine that's actually gonna do that. It's not one of those incentive spirometry like the portable one. No, we're not talking about that one. That's totally different. So the spirometry is with the use of this device, which actually gonna measure those values that we've talked about, the tidal volume, the total lung capacity, the functional residual capacity. Those are the things, and so many others. But at this point, we're just focusing on this one. I don't want you to get so confused. We're just going to limit the studies here, just specific for the COPD. Now, regarding the preparation of this testing, make sure, guys, that when you are taking care of the patient, before you send them to the diagnostic room, you have to determine if your patient is taking any kind of an opioid medication, maybe morphine, uh, hydromorphone, or dilaudid or OxyContin. So these medications are known to cause central nervous system depression, right? And also respiratory depression. And so these medications can really significantly affect the overall function of your lungs. So when you're sending this patient to the laboratory, you really have to inform the respiratory therapist or that diagnostic personnel that your patient is probably taking this and that. And this is something that you need to consult with the physician as well, or the medical provider. Ask them if the doctor would want to hold off onto giving the narcotic analgesic or any kind of opiate to the patient before the testing in order that we can do a much more of exact reading into their lung function. So this is something that you really need to communicate to your patient. Now, also, you have to talk about the use of the bronchodilators just right before the pulmonary function test, because this can possibly give us a false negative reading because they have already been given that dilator to allow airway reopening or, yes, stabilization of the airways. So you really have to talk with the physician if this is something that we need to hold off. All right. Now, another preparation here is to avoid heavy meal at least 4 to 6 hours before the test. So again, let me write down the preparation. So we are considering the communication about the opiate medication before the testing, the use of the bronchodilator just right before the test, because this could give us a false negative result in the PFTs, or the food intake. So we are going to avoid the avoid heavy intake of heavy meal 4 to 6 hours before the test. Let me just put it right there, 4 to 6 hours before PFT. Okay, so these are your preparations. And on top of that is to tell your patient to avoid smoking. Yeah, avoid smoking, because this can give the false positive result of the test. Avoid smoking. And we are going to instruct the patient to wear comfortable clothing when they're going to go to this diagnostic test, because this is something that you can do. Maybe your role in the NCLEX exam could be you're going to be a nurse at the provider's clinic, or maybe you are the med-surg nurse teaching your patient to at least get prepared for this diagnostic test. Okay, so again, think about the opiate use, the bronchodilator use, avoiding a heavy meal 4 to 6 hours before the testing, avoiding smoking, and also making sure that they are wearing the most comfortable type of clothing. And of course, they're going to wear gowns, right, at the hospital. But let's say, for example, if this is going to be done in the outpatient clinic, then this is going to be one of those instructions. Now, after the testing, what you can teach the patient is to have them resume the diet that has been prescribed to them and to resume those medications that have been withheld. Maybe those are the bronchodilators that have been withheld before the testing, or those opiate medications that they've been using chronically for pain control. All right. So again, make sure that you're gonna educate your patients the aftercare. Now let's move on into the diagnostic tests here. And some of these testings were already discussed about 2 days ago. I talked about the anatomy and physiology along with the diagnostic tests. And I might repeat some of those just to kind of emphasize things, but I'll probably focus more on those diagnostic tests I wasn't able to really tackle. And so one of the important diagnostic tests is the chest X-ray. Okay, so this is a test that is easy to conduct, and however, though, this has low sensitivity for diagnosing COPD. Again, this has low sensitivity in diagnosing the COPD. Now, again, I'm going to ask you, what is the definitive test to determine if the patient has the COPD? What is that? I'm asking you right now. Let me see if you can answer through the chat box. Hello. What is that definitive test that you should look at for this patient? Well, again, those are the pulmonary function tests, the PFTs. All right. So the chest X-ray is considered as the secondary diagnostic test. This can show the hyperinflation of the lung fields. Okay, because of the hyperinflated alveoli, there is also going to be uh, flattening of the diaphragm when you're going to look into the chest X-ray, right? And there is also going to be an enlarged retrosternal space in the advanced emphysema. So those are the things that can be captured by the chest X-ray. Now, this is something that is particularly useful during the acute exacerbation in order for the medical provider to rule out conditions like pneumonia or, let's say, pneumothorax. Again, this is going to be a very important diagnostic test, especially when there is exacerbations and to rule out any other conditions like pneumonia or pneumothorax. Now let's go into the next testing here, which is the alpha-1 antitrypsin levels. Remember about this? This is one of those tests that we've talked about, and this is going to be elevated in the patient with emphysema. Okay, and so again, this is a diagnostic test that will measure and will determine the also the patient's personal and family history. And this is something that can possibly done early before the or during the early onset of emphysema, usually around before age 45, or let's say for the non-smokers with the emphysema. Okay, so again, this will measure the alpha-1 antitrypsin level. So this is going to involve the lung tissue exam. And here, this is also going to diagnose pathologically with that permanent enlargement of the air spaces. And we are going to, we're actually pertaining to the inflation of the terminal bronchioles. And that is because, of course, with the destruction of the alveolar walls. Now, here we have the ABGs, the arterial blood gases. So don't forget about this one. This is going to be used when there is going to be some exacerbation of the COPD, and this will reveal some chronic carbon dioxide retention and also low oxygen levels in the bloodstream. And so this is also going to tell us how well the lungs are functioning in its gas exchange, and also how they're going to be able to really manage in stabilizing the acid base balance inside the body. Okay, don't forget about the ABGs. All right, we're not really gonna talk today about the normal values and the compensations. We're gonna have to do that separately in the fluids and electrolytes. All right, now we're gonna talk about the different treatment options. And this is standard to all COPD patients, okay? So again, I really want you to put yourself as the primary nurse taking care of this patient. So here are the treatment options. So one of the treatment modality here is really to cause smoking cessation. This is very important. And quitting smoking can really slow down the progression of the COPD, and it can improve the patient's survival rate, although it doesn't really completely reverse the lung damage, but it can help. Okay, so we are also going to talk about the medications that can be used for this patient that may have an exacerbation of the COPD, and we are going to touch base about the different medications here, such as the anticholinergics. And please be reminded, guys, this is the generic name of medications that we will often encounter in the clinical setting. The ipratropium bromide. Think about that. That is the anticholinergic that is going to be used together with the beta 2 agonists. Okay. And so the anticholinergic or the ipratropium are going to be used as well during severe symptoms. Now, talking about the beta 2 adrenergic agonists. Okay, so what is this classification of medication? This is going to cause the relaxation of the beta 2 receptors that are actually found in the smooth muscles of the lungs, the airway. Again, beta 2 adrenergic agonists, and this is represented by our medication albuterol. They are going to cause relaxation of the bronchial smooth muscles. Okay. Think about that relaxation. This is the primary medication that will be doing this drug action. It will cause the airway to be more relaxed. It will allow reopening of those restricted or narrowed airways. Okay. Now, the beta 2 agonists or the beta 2 adrenergic agonist is going to provide quick relief. There's also that long-acting beta-2 agonist like the salmeterol. Okay, so albuterol is the rapid-acting, whereas there's also that long-acting type of beta-2 adrenergic. Salmeterol. That's the long acting. It simply means that it doesn't work instantaneously. It will take a while for this medication to take effect. All right. Now, the patient will also be using this, what we call as the combined inhalers. So it contains both the ipratropium and the albuterol. And this can really enhance the bronchodilation and it will really improve the patient's compliance to using the treatment. Okay, so that is what we call as the combined inhalers. Now, please take note, guys, that on top of these medications, the patient might also benefit from the use of the inhaled corticosteroids, and these are your budesonide and the fluticasone. Your key suffix right here is the zone. That stands for the corticosteroids. Okay, fluticasone and the budesonide. All right. Please pay attention here regarding the inhaled. This is inhaled corticosteroids. So what is the purpose of the inhaled corticosteroids? They are going to cause anti-inflammation. Okay, so this is to prevent the inflammatory process inside the lungs, the airways, the alveoli, and this is going to be used with the long-acting bronchodilators, such as the salmeterol. Okay, and this is going to be used for those patients that may have severe symptoms or, let's say, frequent exacerbations. All right. Now, another classification or group of medication that you will expect to be incorporated in their treatment is the theophylline. Okay. So this is going to be given as an oral form. Again, theophylline can be given as an oral form. And this is somewhat kind of controversial in the most recent modality because of its very narrow therapeutic index. Okay, so simply means that this medication can have so many side effects. And so the popularity for this medication is actually going down because of the side effects that patients have been complaining about. But again, this still can be used. All right. Now, we also have the phosphodiesterase 4 inhibitor. So what are these medications? Of course, this is represented by the roflumilast. And these medications can actually help relax the smooth muscles, and they're going to reduce the inflammation, and they're going to potentially lower the risk of the exacerbations. Again, these are your phosphodiesterase 4 inhibitors. So again, this will also help the smooth muscles of the lungs or the airways, and will also reduce the inflammation, and again, will lower the frequent exacerbations. So that's the significance about this classification. Now, part of the therapy here is to include the oxygen therapy, which will really improve the survival of our patient. Again, I'm putting here low flow oxygen. The patient with a COPD will not require a high flow level because this is going to cause some toxicity. The patient will end up not breathing anymore if we give them high concentration of oxygen because they are used to low levels of oxygen that is only their stimulus to breathe. And so if we're going to give them high concentrations, maybe 15 liters of O2, no, don't do that. It will cause them to stop breathing because, again, the low oxygen level is the only stimulus for them to breathe. All right, please take note of that. That's why our patient will only require small amounts of O2, let's say 1 to 2 liters, in order for them to hang between 88 or 92%. And that's safe for them. We don't want to overdo. We don't want to make their oxygen levels 95% or 100%. No, don't do that. Okay. Now, there's also going to be a need for us to facilitate the pulmonary rehabilitation of this patient. And this is something that the medical provider will also recommend. And the Puma Rehab is going to include the education, exercises, physiotherapy, and also to um, promote patients' tolerance to the exercise and also their quality of life. Now, talking about the vaccination here, we are touching about the annual influenza vaccination and the pneumococcal vaccines that are highly recommended for all COPD patients to prevent the respiratory infections. And then there's also a possibility of the antibiotic therapy if in case their COPD exacerbation is accompanied by some infection, wherein they're going to end up with increasing sputum production, or let's say they have some worsening in their shortness of breath. Again, infection that is accompanying the COPD exacerbation. Now we're going to talk about the surgery, and this is going to be indicated when there is way too much of lung impairment. And so the surgical procedure will be probably the lung resection, or it could be the transplantation of a new lung. And this is really going to be beneficial for those selected patients. But again, this will really require some careful consideration because of the risk and the benefits that need to be uh, talked between the patient and the care provider. Okay. All right. Now we are going to talk about the different treatment guidelines here. So basically, another level of the guidelines. So these approaches are basically going to be varied. Okay, and this is going to be based on the severity and also the frequency of the manifestation. And so let's start with the low risk exacerbation. And so, guys, this is considered as the patient having 0 to 1 exacerbations per year. Again, that is considered as low risk. There's only 0 or 1 exacerbations in 1 year. Now, for that kind of exacerbation, this patient will require some short-acting bronchodilators such as the albuterol, and this is going to be the first line of defense. Okay, so again, we are going to start with the use of the albuterol, which is the short-acting bronchodilator, and this is going to manage their acute manifestations. Now, again, please recall that this albuterol will act quickly onto relaxing the smooth muscles around the airways, and this is something that is going to be administered when the patient experiences increasing breathlessness. Okay, so the albuterol is intended for acute relief of what do you call this, like dyspnea or breathlessness. Now, talking about the long-acting bronchodilators. So this is what we call as the step up, wherein the patient really would be required to use this whenever the symptoms will persist, even though they have been using the short-acting bronchodilators. And so there is a need for them to add the long-acting bronchodilators such as the salmeterol or the tiotropium. Okay, so again, that is the step up. Now, what's the benefit of using the long-acting bronchodilator? Well, these are going to provide the patient much more sustained relief. Why? Well, of course, this is a long-acting, right? So when you're talking about the long-acting, it will work. The drug action will be delayed. However, the duration of the drug action will be much more sustained. That's why they refer to as the long acting. Slow acting, but their duration is lengthened and they're designed that way so that the patient can have much more sustained relief. Okay, and so the reason for that is to improve the patient's overall lung function, and this can reduce the frequency of the symptoms. Now, we're going to talk about the inhaled corticosteroids. So, this is also going to be used to provide additional control of the exacerbation. So, the dose here that will be prescribed will be the lowest dose. Okay. And in some cases, the patient will be getting the inhaled corticosteroids. And again, the reason that we are going to administer this is to reduce inflammation. That's the reason why we are administering the corticosteroids, reducing inflammation. And where the inflammation is, of course, the airways. So when you are gonna have to, when you're gonna teach this patient that will be using the corticosteroids, especially if this is going to be used in a long-term basis, you have to teach them to use this cautiously, okay? Because it can also have some major side effects. There will be some increase in the blood sugar, right? Let me just write here, BLD, sugar, hyperglycemia, and also the incidence of the osteoporosis. Remember that with the corticosteroid use, this can cause demineralization of the bone structure. And there's also weight gain because of the retention of the salt, the sodium, and water. So the weight gain is going to be significant. All right. And of course, watch for their blood pressure because it can potentially elevate their blood pressure. And why there is elevation of the blood pressure? It's because of the retention of sodium and water. That's why they are going to end up with high blood pressure. Right? That's the salt and water retained in the bloodstream. Okay? All righty. I hope everyone is still with us. Now, we are going to talk about the high risk exacerbation of COPD. And so this is defined as having at least 2 or more exacerbations within a year. So, what would be included in the treatment for this patient? Well, again, we're gonna include here the regular use of the long-acting bronchodilators, such as the salmeterol, and also the the patient should be in the regular long-acting bronchodilators. They're also going to be using the uh, inhaled corticosteroids, theophylline. Yes, somebody said about the infection because of the prolonged use of the steroid, especially if they are going to be using the oral form, the prednisone. This can really predispose them to some infections because of the immunosuppression. All right. So here, the theophylline or the ruflumilast is going to be included in this high risk type of exacerbation. This is what we call as the phosphodiesterase 4 inhibitor, which is going to again reduce the inflammation in the airways. And again, this will relax the smooth muscles in the airway. All right. Now, with the high risk exacerbation, they're going to benefit with the use of the continuous oxygen, especially if they're going to be hypoxemic. And again, the oxygen rate will be low flow O2. Low flow O2. So this is something that you need to emphasize in the administration of oxygen, especially if they have it at home. When they're using it for continual use, they need to stick to that low flow, not high flow, because they're going to end up with that toxicity. Now, we're also going to implement or facilitate their pulmonary rehabilitation. And this is going to really help them out with focusing their exercise training, their nutrition, also educating the patients about the different treatments. Okay. It will benefit them with the conditioning and also reducing their readmissions to the hospitals. And guys, I've been in the workforce for so many years that we often will have some patients that you will consider as frequent flyers. You will recognize them in your unit. If you're going to be working in the med surg or let's say telemetry, probably they're going to come back in your unit at least every 2 to 3 months, especially for those end stage type. So they're going to be coming in and out of the hospital with the same kind of therapy. And for those who are really non-compliant, especially for those COPDs that are still smoking, yeah, they're the most challenging group of people that you'll be dealing with. And so here, we are going to be talking about the treatment in the acute phase, all right? Especially acute phase COPD exacerbation. And here are going to be the different treatment protocols in order to manage their exacerbation. So again, we're going to see here the bronchodilators, the beta-2 adrenergics with the anticholinergic. Hey guys, anticholinergic, please think about this one. Remember that this is going to cause some retention of urine. Although this is not going to really cause as bad of a urinary retention compared, compared to the oral anticholinergics, but it still can cause urinary retention. So this might be asked in the NCLEX regarding what side effect you will be expecting in this patient that will be using the anticholinergics. Again, this will cause urinary retention and will often complicate when your patient has a history of benign prostatic hypertrophy. Okay, so all the more that they're going to have some problems with the urinary retention if they're using the anticholinergic. All right, so that is just, I'm just throwing it out there just in case. Now, the bronchodilators again will be using the beta-2 adrenergic agonist, the albuterol. And again, this is going to stimulate the beta-2 adrenergic receptors in the airways. The anticholinergics, which are actually going to block the acetylcholine receptors. And this is going to cause a reduction in the inflammation and allowing much more open airway. And then we are going to expect that these medications can be administered at home. It could be in a form of a nebulizer, a nebulization, or it can be administered through the MDI, those small gadgets, all right? Now, we're going to expect here that there will be administration of the systemic corticosteroid. So if your patient has an acute exacerbation, they're going to end up with possibly first the use of the methylprednisolone IV because of its rapid anti-inflammatory effect. And towards the discharge day, the doctor or the medical provider we'll probably shift or change that to the oral form, which is the prednisone. Okay. So again, these are your systemic corticosteroids. And again, look for those possible side effects, and they're really going to appear in these patients. And what those are, again, there will be increasing blood sugar, increasing blood pressure. And why? It's because of the retention of the sodium and water in the renal tubules. They're going to be prone to catching nosocomial infections. Okay. So those are the things that you need to watch for, especially when they are going to be treated with the methylprednisolone IV and the prednisone. Again, guys, since we are talking about the prednisone, probably this patient will take this medication for maybe longer than 2-3 weeks. Probably they're going to have to take this medication for quite a long time. So with the prednisone, the medication should be tapered. And this is expected in the treatment. Tapered. It simply means that the medical provider will be ordering varying dosing. Okay? It simply means that it will be, the dosing schedule will be decreasing up until, towards the end of the therapy. We don't want to discontinue the medication so abruptly, because when this happens, this can lead to what? Adrenal crisis. Okay. Why are they going to go into adrenal crisis? Well, because the body is told, since it's actually the adrenal gland, basically the adrenal cortex. This is the organ that basically produce the innate steroid, right? The glucocorticoid. So when a person will be taking an external source of glucocorticoids, such as the corticosteroids, this will cause a stop in the body's production of the glucocorticoid, because, hey, I got something else from outside the body. I'm not going to do anything about it. I'll just lay here and chill. And so by the time when the person will immediately stop using that corticosteroid, because they probably did not understand the treatment. And so when the patient abruptly discontinue using the steroid, the body will not be able to produce the innate or the internal glucocorticoid, because again, it was chilling, right? And so in order to mitigate this issue, in order to prevent that from happening, we are going to taper the dose. It simply means that maybe during the second week before the medication gets discontinued, the dose will be probably 2 milligrams per day. And then probably the next week, it will be reduced to 1 milligram, maybe an interval of 1 day. Then there will be at least slow reduction of the dosing schedule. Again, our goal for that is to prevent adrenal crisis. And someone just said something about the overweight. Yes, that is, of course, the accumulation of the adipose tissue. It's because the cortisol or the glucocorticoid will cause the lipolysis. And of course, this is going to cause them to have the fat deposition. So again, you will think about the Cushing's type, Cushing's disease, or yes, that can potentially happen to this patient that will be placed on a long-term glucocorticoid therapy. Okay, so there will have some moon phase, urinary retention, high blood pressure, their glucose will go up. And guys, here we go. If your patient is diabetic, let me just put it here. Diabetic, it could be either type 1 or type 2. So when your patient is diabetic, and if they're going to have a COPD, your role here is to watch for the patient's blood sugar, because it's definitely going to make their blood sugar spike. And definitely your treatment here will be increased. And I'm talking about the use of additional insulin, regular maybe, in order to manage their blood sugar, because we don't want to cause excess blood sugar in this patient with this kind of therapy, because it is expected that it will cause hyperglycemia. So at this point, when they're going to be with the glucocorticoid therapy, we want to make sure that their diabetes is well controlled as well. All right, so please take note of that. So when they're in the hospital, the frequency of the blood sugar testing will probably be much more frequent, maybe 4 times a day, AC and HS. So every before meal and at bedtime. So our finger stick of the blood sugar testing will be every before meal to see how their blood sugar is, and just before bedtime. This is the usual frequency in checking their blood sugar, and then we're going to have to base the amount of the insulin into their levels of blood sugar. Okay, so there is that sliding scale of insulin. Okay. So expect that this is probably going to come out in your exam. Sliding scale insulin. Alrighty, wonderful. All right, now I got so much written already on the screen. Let me remove those. Now moving ahead here, we're gonna again, the corticosteroids actually gonna be useful in reducing the airway inflammation. There's also reduction in the mucus production, because if there is poor control in the inflammation within the lung tissue or the bronchus or the bronchioles, this can hasten the production of it can increase the production of the mucus. And so make sure that we are administering the systemic corticosteroid in order to prevent this. Now, for the antibiotics, talking about the antibiotics, this is going to be prescribed for the patient with, let's say, moderate or severe exacerbation, especially if there are signs of bacterial infection. So how do we know there is a possibility that they're going to be having some bacterial infection? Well, it could be that the patient will have an accompanying sputum purulence. So take a look into the characteristic, the color of the patient's sputum. And probably they're going to be complaining about high fever or fever. And looking into their laboratory report, there will be elevation of the white blood cell count. WBC is elevated. Okay? WBC is elevated at this point. Now, again, look into the sputum color, which is going to be purulent, and then there is also fever. So these are your signs that your patient probably have the infection. Now, the antibiotics that we are talking about here are those antibiotics that actually gonna target those pathogens like Haemophilus influenza, or let's say the Streptococcus type of pneumoniae. Now, moving ahead here with acute exacerbation, we are going to talk about the supplemental oxygen, and this is going to be required for those patients that have the hypoxemia in order to maintain adequate oxygenation. Now, we are going to aim here that our patient will maintain their oxygen at least 88 to 92%. Okay, this is our goal. We don't want our patient to have 98% if they have COPD. That is unrealistic. Okay, don't be happy when you're going to administer them with a high flow, because when you do that, it's just not going to last long. Your patient will be having oxygen toxicity. They will stop breathing. So make sure that you're delivering the low flow oxygen. So how are we going to deliver that oxygen? We can deliver that through a nasal cannula, or it could be the Venturi mask. Okay. the venturi mask is the safest route or method in the delivery of the oxygen. Again, we are going to use this venturi mask, and we are going to collaborate with the respiratory therapist with this, because the venturi mask will have different levels here. There are going to be some differences in the fractionation of the fraction of the O2, and so make sure that we're going to adhere to that kind of gauge so that we are going to safely administer the oxygen to this patient. Again, we don't want to cause toxicity, O2 toxicity to this patient. Now, talking about the non-invasive ventilation therapy. So what is this? So you might have encountered this for those patients with the COPD. So they're probably using those BiPAP, or known as the bilevel positive airway pressure, or it could be the CPAP, which is the continuous positive airway pressure. And these two treatment modalities can actually reduce the work of the patient's breathing. It can also improve the gas exchange, and it will also decrease their need for invasive mechanical ventilation. Again, these two will reduce the work of the patient's breathing. It can also improve the gas exchange, and it will decrease the need for mechanical ventilation. But this is something that you should also focus, because for those patients that are getting more confused, they usually will not be able to tolerate wearing the BiPAP, which is somewhat kind of claustrophobic. Have you seen those masks when they're wearing the BiPAP and CPAP? Yeah, it is kind of claustrophobic. They just don't want that thing over their face. And so some of these patients probably will end up removing the mask, or probably providing them with a sitter in order to help out in keeping those masks on their faces. Yeah, so quite challenging, especially when you're dealing with an elderly person or a very confused patient with a COPD exacerbation. Okay, now if these treatment modalities will fail, then we have the last option, which is basically the intubation. Okay, and the patient will be connected to the mechanical vent, and this is really going to be the last modality if the patient's condition does not stabilize with the other treatments. Okay, and so the patient will be, of course, having that endotracheal tube being inserted into the airway, and of course this will be regulated. This has to be checked every now and then. And part of your care here as an ICU nurse with a vented patient is to check for the symmetry of their lung expansion, because sometimes this can cause some complications. All right. So you really have to pay attention into the modality here, especially with mechanical ventilation. And we'll talk a little bit more of that in a separate topic regarding mechanical vent treatment. Now we're going to talk about the, what do we have it? We're going to talk about the nursing actions here. So this will be our main focus this time, and a very critical aspect of care that can possibly or significantly improve the outcomes of your patient and also their quality of life. So part of your care here, simply, probably you're going to be asked about the simplest nursing care during the exacerbation. So positioning the patient is very important. You're going to put them in a high Fowler's position, sitting upright at least 90 degrees, and this will allow them to have maximum lung expansion, makes their breathing much easier. And also, we're going to have to manage their secretions and to make sure that they're able to cough effectively, expectorate the mucus, and also assist them with some suctioning, okay, if they're not going to be able to effectively do it. Now, suctioning is very important because this can really cause a blockage into their airway. Now, with the breathing exercises, this is another simple step that can really help out the patient. We have to teach them about the deep breathing, and of course, with the use of that incentive spirometer. Now, here we go. We have the IS involved here. Okay, so this will really help out in allowing them to re-expand their lungs and also improve the lung function. And back again to the medication treatment, we have the different modalities there. So whatever long-acting or rapid-acting anticholinergics, beta-2 adrenergics, the steroids, or those other medications that we have talked about, this will really assist the patient in allowing them to have much more controlled symptoms. Now, the oxygen therapy, again, is very important, and I cannot really emphasize enough that we are going to deliver this as low dose. Emphasizing again, low dose O2. And our goal, again, should be 88 to 92%. We don't want to achieve 99, just so impossible. Okay, low dose O2. Again, because the low oxygen is their only drive or stimulus to breathe. Okay, if we're going to give them a high O2, they're going to stop breathing. That's it. Now, in some cases, though, they might need some kind of a rescue. And so they probably would be needing at least like 2 to 4 liters in some instances, but not for prolonged time. Okay, but most of the time they're going to be sticking into the 1 to 2 liters. This is only indicated when they have higher PaCO2 just for a brief period. We don't want them to keep using this range. Okay, our goal is to have them use the low flow oxygen. Okay, now we also have to make sure that they're using the Venturi mask 40%, and this is the safest way in delivering the oxygen for this patient. Again, the Venturi mask. Now, with again, this is what I just said. The low O2 is their only stimulus to breathe, and so we have to focus onto the low O2 delivery. Part of the care here is going to involve skin care, because for those chronic O2 users, they're going to be having those possible ulcers behind the ears, ulcers that could convert into chronic wounds with a constant pressure into the behind the ears. I've seen those patients that have been using those nasal cannula tubing. They end up with the chronic ulcers behind the ears, and this is really going to complicate all the more. So we have to make sure we are checking the skin irritation when we are admitting the patient, especially for those wearing the nasal cannula. Make sure that they're wearing the ear protectors. Have you used those? Or have you applied those ear protectors that are actually type of like a padding to the tubing? Have you seen those guys? Which you can actually slip into the oxygen tubing in order to add cushion, prevent pressure into the skin behind the ear. Okay, so you have to add this ear protectors. Now, there's also a need for us to maintain the nutrition of the patient, because they're really going to require adequate nutrition, because the increasing breathing effort will raise their caloric needs. So make sure that we are providing them the appropriate, adequate nutrition. Now, again, we are going to weigh our patient. Why? Why are we weighing your patient? For what? Well, remember that we are probably putting them in that glucocorticoid therapy. Remember about the weight gain, water retention, hyperglycemia, hypertension. Yes, that's why we are going to weigh in order to identify any kind of significant changes that may indicate nutritional issues or maybe fluid retention. And again, if you're going to take care of a patient that may have a chronic, or let's say CHF, a congestive heart failure, for those patients that may have a CHF with the COPD and using glucocorticoid, remember about the complication of having a fluid volume overload. This will add more stress into the ventricles. So you gotta watch this patient. that they might go into an exacerbation of CHF. They're going to end up with shortness of breathing, probably in one of those days that you're not carefully watching the intake and output of your patient. They're going to go into pulmonary edema. And again, if you're not paying attention into the intake and output of the patient, the weight daily, yeah, they're going to go into pulmonary edema. And this is a life-threatening condition. And again, guys, don't be too lax when you're seeing an increasing, a trending up of the weight. Yeah, you would say, yeah, it's still acceptable. It's not really 2 pounds weight gain. Yeah, but if you're going to compare it to their baseline weight during admission, if there is such increase, then that is considered significant. All right. So don't just stick into the 2.2 increment daily, because again, if there is a trend that the patient's weight is going up, that is already significant. And so we're talking about fluid volume overload. Again, protect your patient from any complication. Again, pulmonary edema is not a joke. Not a joke. All right. So you got to be doing your preventive measures in order for this patient to avoid this type of complication. Now, the breathing techniques, what is this? This is again about the deep breathing exercises, the diaphragmatic breathing, use of pursed lip breathing. And so how are we going to implement this, especially for the newly diagnosed COPD? So what we're going to do is to start with recommending them to lie on their back with the knees bent, and they're going to place their hand on the abdomen and feel it to rise and also fall. Okay, so this is going to be your starter. Now, if you're going to teach them about the pursed lip breathing, if they're really a newbie COPD, then you're going to advise the patient to shape their lips as if they're whistling, and they're going to inhale through the nose and teach them to exhale slowly through the mouth. Because with a slow exhalation process, this will allow much more effective removal of the air from the alveoli. Okay. Now, with the modality here, like the positive expiratory pressure device, I hope that you're familiar with this one. So what is this positive expiratory pressure device? What is this? This is basically with the use of the capella. This is that device. So what is the relevance of this device? This is going to help clear their airway of the secretions. Again, think about the secretions that will be accumulating, especially for those newly admitted patients. And so this will cause the oscillation. So when the patient takes a deep breath, it will cause vibration into their airways. And that vibration can cause dislodgement of the mucus that have been kind of sticking into the airway, the gunk that have been sticking into the bronchioles. The device will actually cause those to get dislodged and then promote it to be expectorated. So this is something that would really benefit your patient. Again, that is your positive expiratory pressure device. Now, talking about the exercise conditioning. So what is this? Well, you're not just going to allow your patient to be sitting on the chair the whole day. Nah, no. So even though they're going to have the exacerbation, you're going to start progressing their activities, allowing them to slowly engage themselves into daily walking at a self-paced rate. Of course, we're going to have to consider the dyspnea, right? So, of course, if they become so dyspneic, they have to pause and have to keep moving again until they will get used to that pattern. Now, we're also going to recommend 20 minutes of walking daily, at least 2 to 3 times per week. And also, we're going to have to include in their activity plan to assess the physical limitations and also activities that will include rest periods. And we're also going to allow for those older adults, make sure that their environment is kind of friendly that they will have some areas or spots that they can relax, maybe some benches that they can use when they start to get short of breath. They can just stop and try to catch their breath. Now, part of the care here is to really support the patient and also educate them about the emotional impact of the disease process. Make sure that this is available to the patient and their family, because the family really is going to be the main helpers when the patient is going to need a lot of extra help at home. And we're going to have to talk to them about the disease process for better understanding that they can uh, accommodate or adjust to the new lifestyle when we are modifying them. And also, we're going to have to also arrange the home care services. So even though when we have the case managers that will be involved in the care of our patients, they definitely need our help as well. We are the informers. We are going to be the bridge in order that we're going to notify them that, hey, our patient, they are just newly diagnosed. They don't have this kind of equipment at home. This is their living situation. They don't have enough help at home. They are living on the second floor or third floor, or let's say they don't have this equipment yet. So you're going to be the bridge to tell the case manager that these are some of the current living condition that your patient have in order that you can help out during the transition phase. Now, part of the education and the rehab of your patient in the home setting is to um, progress their fluid intake at least 2 to 3 liters per day if there are no contraindications. And this is to thin the mucus, which is very important. Again, we have to encourage the intake of fluids unless it is contraindicated, because this will help out in thinning the mucus. Now, talking about another modality of treatment here is the use of the incentive spirometer. I'm not quite sure if you have done some education to your patient with the use of the IS, if they have a COPD. I'm not quite sure if you have done this with your patient, because this is we usually see in a post-op patient, but not often in a patient with a COPD. This is very important, guys. The use of the incentive spirometer is really important, okay? And um, okay, there we have a question from Virtuous Lady. Can they take Lasix to reduce the fluid? Well, of course, in a situation where there is pulmonary edema, we don't want to compromise the ABCs, right? And so this is the easiest and the most effective treatment during that critical phase. You have to really expect when you're going to notify the physician about the fluid overload, that now they have some respiratory distress, they're hypoxemic, they're already tachypnic in the 30s. They're just like feeling that impending doom. Yes, Lasix, the loop diuretic, is something that can be used in the situation in order to rapidly remove the excess fluid accumulating in their system. Okay. But again, there are way too many factors that you're going to consider. If they're going to be using, if they have been using maybe some digoxin for their maintenance dose for the CHF, yes, you really have to open your eyes while you're reading the scenario, because you really have to watch for those labs. Are they hypokalemic when you are giving the Lasix while they have the digoxin on board? So we're going to talk a little bit more of that when we are going to touch with the congestive heart failure, focusing into the diuretic therapy and also the use of digoxin. But again, like your question, um, yes, of course, Lasix would probably be used in that situation when there is pulmonary edema. Now, back to the incentive spirometer. We want to make sure that we are really observing the patient in order that they can do this procedure carefully and correctly. Because probably you're just showing them the paper or the instruction, just handing them out, and probably they did not really understand the instruction. So before you're gonna end up leaving the patient to read the pamphlet, make sure that you have them do a return demonstration. Have to watch them how they use it. So make sure that they're gonna seal they are gonna do that tight seal around the mouthpiece. Okay, make sure that they do that, or else there will be leaking of the air. And make sure that they have to inhale deeply and hold their breath for at least 3 to 5 seconds. Okay. All right. Again, you're going to instruct the patient to form a tight seal around the mouthpiece, which is right here. And then you're going to instruct them to inhale deeply for about 3 seconds. When they do that, this section right here will start to go up. This will elevate. Okay. Now, guys, for the COPD, don't be too like prudent, or like I should say, don't put too much expectations on your patient when they have COPD. All right, don't do that. Start with the lowest goal. Maybe start with a 500. And if they can do that more often without difficulty, then the next time that they're going to use the incentive spirometer, then up it a little bit, maybe 750. Make it gradual in order that they can do a whole lot more of the deep breathing effectively. Don't rush them into reaching that goal like 2 liters. That is way too much. Our patient here has COPD. They already have trouble in taking a deep breath. So be patient with them. Make sure that you're going to gradually increase the goal. All right. Just telling you out there, because this is really the reality of these patients. Now, again, the purpose of using the incentive spirometer is to have them elevate this device right here. And this is their indicator that they are breathing deeply and effectively. And our main goal really for this therapy is to promote lung expansion. Okay? That is our goal. You got to be patient, guys. Our patients are probably in their 60s, 70s. Yes, the COPD patients are in the elderly population, so you got to be patient. And along with that, most of the COPD patients are quite impatient themselves. They want to get things done right away. Because of the shortness of breathing, they just can't wait for those stuff that they need. So you got to be patient. Their behavior is not, they're not taking it against you. It's just the way how their behavior is like. I mean, yeah, sometimes you can get offended by this kind of behavior, but once you understand how they try to change their lifestyle, it's really going to make them so demanding. So just be patient with them. It's just expected. But it's not an excuse that their behavior will be like that. You have to set boundaries as well. But I'm just throwing it out there. It will also probably gonna tick you off. So just be open. Keep an open mind when you're treating this COPD type patients. All right. So when I reviewed the previous video, I was checking into one of the comments, and thank you for that viewer that actually mentioned something about the other type of embolism, which is actually the fat embolism. Yes, the reason that I did not include the fat embolism in that discussion, because I don't want to really cause some more confusion, because the modality of the treatment with the main pulmonary embolism is so different. There might be some similarities, but the approach into dealing this patient, especially the nursing care, is way different. Okay, and so I'm gonna include here some sections about the fat embolism and also the air embolism and the amniotic. So this will be an extra for that in order that we can have some differentiation. And again, this was my intent to have it done separately because of the different approaches. So we'll tackle now the fat embolism, which is one of those types that can happen when there is now an escape of those fat globules. And this is going to be spread into the bloodstream, or it will lodge into the pulmonary vasculature when there is now probably a fracture of the long bones, or it could be caused by the orthopedic surgery, maybe total knee replacement, total hip replacement. And so this can really disrupt the fatty tissue and inadvertently will cause the release of these fat globules into the bloodstream. Now, another cause for the fat embolism is the trauma. Maybe there is severe soft tissue trauma that can cause the spread of the fat emboli, or it could be caused by the liposuction. Okay, for those people that have this kind of procedure, liposuction could be burns or maybe acute pancreatitis. This can lead to the fat embolism. Now, what is the approach of treatment here? Well, the primary goal in treating the fat embolism basically is to alleviate the hypoxemia. And our goal here is to improve the oxygenation. So with this is going to be a life-threatening issue. The patient will probably end up with a mechanical ventilation if the oxygen therapy is going to fail, or the size of the fat embolus is way too big that's actually lodging into major pulmonary artery. So again, the size of the fat emboli will matter. So the smaller it is, again, it will be a milder form of embolism, milder signs and symptoms. However, if there is a fatty globule that has lodged into a huge section of the pulmonary artery, then this will really compromise the oxygenation and could really cause lung collapse instantaneously. That's why some people really die within just a few minutes after they suffer the embolism. Now, again, mechanical ventilation will be needed if there is huge effect of that embolism. And one of the treatments is the administration of the corticosteroids, such as the methylprednisolone. This is given IV. I've researched into the different studies here. This is going to be, this is a somewhat controversial. I've looked into the different evidence-based studies. This is used, however, this is controversial, but it seemed to be effective. Okay. Now, another thing is that there is also a possible indication of starting the anticoagulation, especially for those high-risk patients. And so what we're going to expect here is the inclusion of those anticoagulants in order to prevent the enlargement of the embolus that was started by a fat embolus. Okay, remember that if there is a presence of whatever form that has clogged into that respiratory or the artery, this can cause deposition and an increase in the size of the embolus. Now, we're also going to monitor the patient's respiratory status and oxygenation, and this is really going to play a huge part in the nursing care. We're going to have to administer the oxygen. And of course, if there is some complication with the blood supply to the brain, you have to watch for the neurological changes. Also provide emotional support to the patient and family. This is instantaneous. It's just like a patient is having an MI. And this is really going to be a sudden change into their status. Everybody will be in such shock and surprise. Nobody can really prepare you for this kind of incident. Now, with the air embolism, this is a different type as well, wherein the causes are going to be the following. Maybe there is a penetrating wound into the chest or the abdominal area, or maybe there is some kind of a surgical procedures that allowed the air to get in the system in the venous circulation. Okay, and here there's also probably the insertion of the central vein catheterization, insertion of the huge IJ IV. So that can also lead to the entry of the emboli, the air itself, into the respiratory system. Now, diving accidents can also lead to that. What we're going to do here, guys, if you're going to encounter this condition, especially in the acute care setting, if you're suspecting that this patient suddenly developed the air embolism, and you're associating the kind of procedure the patient just had, let's say insertion of the central line, surgical procedure, or yeah, you're going to have to put the patient in a Trendelenburg position in order to prevent lodging of the air into the pulmonary artery. That is the primary action that we're going to do. And also, we're going to deliver 100% oxygen in order to prevent the hypoxemia. And this is also to eliminate the nitrogen from the bloodstream and will also reduce the size of the air bubbles. And another modality here is to aspirate the air through the central venous catheter. Okay. Again, that is quite invasive. Now, part of the care here is to place the patient in the hyperbaric oxygen therapy. And this is only done in the severe cases. And if we are going to ask, okay, what would be the pharmacological treatment here? Nothing is specific. So the medical provider will order the pharmacological action, pharmacological therapy according to the symptoms. So the delivery of 100% oxygen is really one of the mainstays here. Again, don't forget putting your patient in Trendelenburg's position as soon as you have figured out what could have led into this air embolism. Don't just put them in Trendelenburg position without thinking first. All right? Don't do that. All right, now we're going to have to make sure that the patient has oxygenation, supplement oxygen in order to fight off the hypoxemia. We have to address if there's any respiratory distress, and also possibly assist the medical provider in aspirating the air emboli. Now, we're going to talk about the last type of embolism, which is basically in OB. I was thinking maybe I'll just include it in OB, but heck, I'll just include this right now. So another type is the amniotic fluid embolism. So what is this? This is basically going to happen when the woman is probably just delivered the baby vaginally, or it could happen after the C-section, or it could be as a result to abruptio placenta, or if there is a trauma to the uterine vasculature, all right, or maybe with the use of some instruments in a GYN procedure, okay. So those are the things that could lead into the amniotic fluid embolism. Of course, this is only going to happen in the mother delivering the baby, right? And so what are we going to do here? Of course, this can happen instantaneously. So probably this can happen while the patient is still in the delivery room or while the patient is still in the OR. All right. So the team will definitely treat this with the use of the oxygen therapy. And if it fails, then they're going to proceed with dealing it or incorporating with the use of the mechanical ventilator. Now, part of the care here is with the transfusion of the blood products, because possibly there is some issue with the patient's coagulation. This can also cause some disseminated intravascular coagulation. Again, guys, the amniotic fluid embolism can lead into the release of the inflammatories, the pro-inflammatories, which can cause the disseminated intravascular coagulation. And so the body will be depleted of those clotting factors and also the platelets. So there will be a need for us to transfuse the patient with the blood products. It could be the FFP in order to treat the bleeding disorder and also to stop the hemorrhage. And of course, we're going to have to support the treatment with the administration of the inotropic agents, and these are your dopamine and dobutamine. Guys, please pay attention here. I did not include this in the pulmonary embolism, so I apologize, but the use of the dopamine, the inotropic agents, can also be used in the pulmonary, we just erase that, the pulmonary embolism, hang on, eraser, especially if there is a profound drop in the blood pressure. Okay, so again, expect the use of the inotropic agents if there is a significant drop in the blood pressure and also the cardiac output. Okay, So what are you going to expect again? There will be incorporation of the inotropic drugs like the dopamine, dobutamine, in order to maintain perfusion of the major organs. Okay, we are not gonna will a biopsy force this kind of embolism? What do you mean by will a biopsy course this kind of embolism? I'm not quite sure what you're talking about, the kind of biopsy. Um, yeah, I wish I have some more clarity about that question. All right. Now, the like I've said, if there is a huge involvement, let's say, for example, remember that there is such a huge traffic in the pulmonary circulation. Remember about that. Let me go back into that slide real quick. Let's go back right here. I hope that you can see. Remember that there is a huge traffic in the pulmonary tree, especially if there is like a clot, a huge clot in a case of a massive PE. This will really cause a huge effect into the cardiac function as well. So what's going to happen? This will cause stagnation and backflow of the blood into the right ventricle. This will lead into the right-sided heart failure. When the right-sided heart failure occurs, of course, you're going to expect a drop in the blood pressure, right? And why? It's because the cardiac output is also um, the cardiac output is decreased. Amniocentesis. The amniocentesis has a less, it doesn't really cause that, what do you call this, amniotic fluid embolism, because it doesn't really, well, there is some risk involved, right, with the amniocentesis. So when you're going to have a patient that will undergo this kind of testing, you really have to screen them. Are there any abnormalities in the placement of the placenta? Or do they have a placenta, abruptio placenta or placenta previa? Because if there is going to be a complication with the amniocentesis, let's say, for example, an abnormal separation of the placenta from the lining of the uterus, then that's what's going to cause the amniotic fluid embolism. Not really the amniocentesis itself that can do it, but the complication of the procedure itself, which is possibly caused by the other factors like your placenta previa or the abruptio placenta. So I hope that am I answering your question? And so, yeah, is that the biopsy that you're talking about? I hope so. Now, going back into the involvement of a huge clot lodged into the pulmonary artery, this will lead into the right side of heart failure, which will eventually cause the cardiac output to drop. Yeah, and so the blood pressure will also drop. So what do you expect into the blood supply into the major organs? Yes, there will be compromise in the blood supply to the brain and also the kidneys, liver, everything. And so what are we going to do? We are going to expect the use of the inotropic. And so around this time, probably the patient is already on their way to the ICU. Okay. And so you have to really expect that this is an instantaneous change in the patient's status. You're not going to expect that this patient will stay in the med-surg unit. No, this is a critical change in the patient's condition. So when you're going to call the rapid response, and maybe the patient coded, of course, the team will be right inside the room. And of course, they're going to send this patient to the critical care unit. And so with the administration of the inotropic agents probably will be initiated en route to ICU. Yeah, so this is expected. Okay, thank you for the question. I appreciate that. So guys, we are not going to expect the administration of IV bolus. Why? Why do you think that we're not going to expect the IV bolus when there is a low blood pressure in this scenario? What do you think? I want you to think about why the intravenous I or the IV bolus is not indicated in this scenario. Well, because of the right-sided heart failure, when you're going to increase some more volume into the system, all the more that the patient will be drowning. Okay, so this will worsen the congestive heart failure that just instantaneously happened. Okay, so that's why we're not going to expect IV bolus at this point, even though their blood pressure is lowering down. And so make sure that we have done screen the patient, look into the results, because the pulmonary x-ray or the chest x-ray that can be done rapidly during this sudden change will be available pretty soon. So if there is like rapid change in the size of the heart, yeah, our patient just developed right side heart failure. So again, don't expect administration of boluses here because of the enlargement of the right side of the heart. So what we're going to expect, inotropic agents. Now let's return to that previous slide that we just used. So we are back into the amniotic fluid. So again, the patient in the amniotic fluid embolism will have to use this modality as well, similar to the pulmonary embolism. And again, this is to maintain blood supply um, into the major organs of the body and also the blood supply to the kidneys. That's the reason. Perfusion to the major organs and to also keep that hemodynamic status normal, at least. And expect that in the amniotic fluid embolism, let me erase this one. It is still controversial though, but they have seen some promising effects of the use of the corticosteroids, according to the evidence base that I have checked for the most recent ones. It's still, again, controversial, but had been effective. Now, we're also going to monitor the patient's vital signs all throughout, make sure that they have stable oxygenation, make sure that they have that on. Continuous pulse oximetry is needed, or maybe your patient is already vented, probably en route to ICU. Someone is already doing the hand bagging with the ambu bag. And also, yeah, you got to prepare this emergency interventions. And most often, this will happen. Your patient is going to end up being intubated if they're a full code. Unless they have declared that they are DNR, then there's no intubation. So again, you have to really pay attention into the code status of your patient. Another side that you have to look at. All right. And so part of that, in the midst of the chaos, when this pulmonary embolism, whatever it is, air embolism, fat embolism, the clot type of the blood clot type of embolism, or the amniotic fluid type of embolism, pretty much it will be distressing to the family, the significant other, the patient themselves. So basically, we really need to support them all throughout, make sure that they are getting the correct information, no false reassurances at this point, and make sure that you're really going to touch base with them, update as needed, in order for them to really get engaged with the care. The more that you're going to talk to them, the more confidence that you can gain from the family members. And this is proven, tested and proven. And so that is the end of our lecture. I really thank you for your attendance today. And so I'll be on tomorrow and we will be talking on the hydrothorax, hemothorax, and possibly I'll be touching into the chest drainage system. And I'm sure we probably will touch on that one tomorrow. So I'll see you again. I appreciate your questions. Now that we are seeing more people commenting, I really appreciate that. So if you have any questions that you probably did not post in the chat box, I want you to do that in the comments section so we can review and so that we can reinforce in those areas that you need some clarification. So that's it for today. I thank you and you take care. Have a great day. Bye-bye.